Welcome back to the Therapist Confidential podcast, everybody. I'm your host, Travis Heath, and today we have Scott Reasor with us, who is not a therapist. And this is something we want to do on this podcast. Scott and I were talking before recording here, and I think sometimes therapists can be a little siloed. It's nice to bring people on who have expertise that can inform what we're doing, but maybe from a little bit of a different vantage point. Scott's a career firefighter, paramedic, and also a trainer, so a teacher, which I think will be helpful in what we're talking about today. And, you know, Scott, I hope to talk some about crisis situations you've navigated, death and dying, which is certainly something in your line of work you come up against. And I think therapists could have a lot to learn from you on these topics. So, welcome to the show. And can I ask you to just introduce yourself? What do you think the people might want to know about you?
Yeah, thanks for having me on. As your host just mentioned, my name is Scott Reeser, and I have been involved in fire and EMS and education in the emergency services field for almost 30 years. So, yep, that means I'm old. Um, I've worked as a volunteer and provider, starting out as an EMT, eventually becoming a paramedic, becoming a certified firefighter, and went into a career in the fire service and worked for several different departments in several different states. Eventually started in an EMS training company, and that's currently what I do full time, and still volunteer as a firefighter in my local community, but uh, pay the bills with my education job at this time.
I notice you have a sign behind you. Before we get going, it says chaos coordinator. Can you tell me a little bit about that sign?
Yeah, I have a chaos coordinator sign. That was a gift. My wife gave it to me after a long day of work a while back, and she came home with that. I think she found it at a Hobby Lobby. If anybody's looking for a chaos coordinator sign, uh, but it sits on my desk now or behind my desk, and that's a good description of what it is to be in this line of work, which is to deal with all the different things. Whether you're running a training company and the chaos involved there, or you're working a car accident scene with multiple victims, it's about managing the situation, whether it's good, bad, or ugly.
Yeah, I think that's a good entry point because one thing I want to talk about is navigating crisis situations. I think that's something we share as therapists. Now, perhaps the crises aren't exactly the same or we intervene at different points of the crisis, but the idea of navigating crisis is something that we share. And I'm wondering first, what have you learned about navigating crises in terms of working under pressure? I mean, are there like particular strategies that you use to navigate the pressure and the decision making that come into crisis situations?
Sure, that's a good question. Crisis comes in a lot of different forms, and depending on the level of intensity, you're going to have a slightly different response. So we'll take it from getting toned out for a call when you're working at a fire station or an ambulance station. That's a certain type of crisis that's happened, and it's going to trigger physical reactions that happen within our body. It's going to trigger some mental reactions that happen within our body. And we're going to need to be able to deal with those so we can actually go out and process it. So, whether you're a therapist or whether you're a firefighter, at the end of the day, you have to get control of your own emotions and your own physiological responses to be able to help somebody else. And so, one of the first things we learn, well, not necessarily the first. One of the things we learn as we do this job in my line of work is some different things to help get control of those physiological responses that are happening. So your heart rate's going up, your blood pressure's going up, you're feeling a little more jittery. So simple things like just taking a brief millisecond to take a big deep breath mentally and physically. Even before rolling out the door in the fire truck or in the ambulance, that's something I found helped me a lot. The other thing was also to begin to think about, all right, here is the information I have so far about this situation. I'm a big fan of the Sherlock Holmes books. Um, and so I really like to employ the same critical thinking concepts that we learned from Sherlock Holmes, which is when you have a situation, it was to begin to gather data and begin to break that data down and to organize it. And when you do that, all of a sudden your chaotic scene starts to come into control. So now you're looking at, I have this information and this information. And based on what I know, these are things I can do to help improve the situation possibly. So it's a matter of working the call, working the situation. In therapy, it's there are situations that you guys can encounter that are just as dangerous and critical as what we do. Right? We have those acute psychotic patients that we can interact with. Both you and I have probably been involved in that. Um, that's probably at the top end of the scale, right? That's the most dangerous and the most crucial to try to work through and navigate. And then we have those other things that are a little slower pace. So maybe we have some time to just slow down, talk things out, work things through slowly. So I think that's probably the biggest thing, is just not letting the situation control you, but begin to work through and control the situation as best you can.
Yeah, and some of what you're saying there, Scott, it's like we have to make decisions with incomplete information, you know?
Yeah.
I wonder if you can talk some about that where, like you're saying, you're gathering data, but you have to make important decisions with incomplete information.
Correct, you do, and you also have to be willing to recognize that because your information is incomplete to start with, your decision-making process and the decisions that you make may need to be reevaluated, may need to be changed, and not getting locked into that first impression or that first gut feeling or that first idea that you had about how to resolve the situation. So it's a very fluid and dynamic process. Um, it's something I've learned to enjoy. It's not something that everybody enjoys. I have friends and family who do not enjoy that type of a situation at all, and we've had, conversations about it, and they're like, "I don't get it. I don't understand why you wanna be in that situation. I want things to be nice and tidy and clean and controlled for me at all times." And I'm like, "Yeah, throw the craziness at me, because I understand it's an evolving process." And I don't wanna say there's never a right or wrong response, because there is, but ultimately, there's not a right or wrong response. It's a response, and then you have to be able to adjust to keep it from going right or going wrong. Well, you want it to go right, not wrong, but yeah.
No, I appreciate what you're saying, though. I talk to therapists in training often about, when they're in crisis situations. One of the things we do is we consult with others, right, and then we document our processes. And one thing that they're often worried about is like, well, but what if I consult and I document and what I did was wrong, you know? And it's like, well, you adjust, right? So then it's wrong. And then you have new information and you document that information, and it's evolving dynamic process. And that they struggle with that, I think sometimes, because there's this feeling like you've got to get it right straight out of the gate. And you were playing there with like notions of right and wrong, you know? And that's tricky because in these situations, certainly we can do things sometimes that would not be good, right? That would be not a good decision to make. But I'm thinking sometimes too, there are multiple options that you could take that could potentially be good options to take. And sometimes there's no perfect option to take either. And I think walking through that's really difficult sometimes for people because they want to get that one good option.
Yeah, no, it's true. Everybody wants to have the one good option. I always in EMS, we are a healthcare profession, and so we've all heard the phrase "practicing medicine." It applies. What's the first part of that? Practice. It doesn't mean you're perfecting medicine. You're practicing it. When you practice something, whether you're playing football, whether you're playing basketball, whether you're writing a paper for a college program, you're going to do a series of drafts. You're going to do practice with this where you're not going to get it right each time. And yeah, that kind of stinks when we're dealing with human lives, that we're having to do this with real people in real time, but there is no other way to do it. There's no other way to learn it. There's no other way to go through it. And we do the best we can. And, over time, this is why your clinician who has been in the field practicing for a long period of time has way more ability to handle situations than somebody who's just starting, because of the vast experience that they have, because it's all about experience.
Let me ask you about responsibility because it seems to me that when we are dealing with human lives, we're assuming a lot of responsibility in that process. And that can be a heavy weight for some people to carry. Can you talk some about what you've learned about carrying the responsibility that comes with these sorts of helping professions?
Sure. Um, there is a lot of responsibility. Once again, everything is in degrees that in life. I like to break things down into choices. That's a really easy way to look at it. You start the day off when you wake up with a series of choices. What am I going to wear today? What am I going to eat today? Am I going to even get out of bed today? Right? Those every aspect of our lives is broken down into choices. So when we get into situations where there's high level of responsibility, those choices that are in front of us carry more weight, which can be, create internal stress for us. I can speak from experience from that. The more weight of responsibility you feel in a situation, the more stress you're going to feel. Um, I don't think we're going to dovetail into stress. That may be another topic for another time. But stress is another thing that literally, you know, people think of stress as being bad, but stress is not. Stress is just a reaction to change in our life. When you laugh out loud at a joke, that is a form of stress. It's eustress, right? It's a happiness. When you are crying about something that's sad, that's a form of stress, but it's also a release of stress. So there's all these different, and this ties into what we're talking about with responsibility, because with responsibility comes that stress, and I think that's the thing that I have found personally that is the hardest to deal with, to work through, is managing that part of it. With with emergency medical services, as a paramedic, probably the most critical moment in time, responsibility wise, has been those patients who are so sick or injured that we end up having to give a medication to paralyze them. That stops their breathing. We have to put a tube in to breathe for them. And we take control of that person's life completely in our hands at that point in time. So that's at the very top end of the responsibility level that we have. Um, and in therapy, you don't have to do that, which is good, right? That's not something that you have to do. Um, that puts us into a really small group of people with doctors who are in those types of situations. But also at the same time, we know that because we take on that responsibility, we have a chance to cause a positive impact for that patient by, mitigating something that was really bad happening, taking control of something, and beginning to improve their outcome, with the known risk that there's a chance things could go bad or get worse for them. Um, so yeah, with responsibility comes risk.
This has me wondering, and I imagine some of my therapist colleagues are probably wondering this too, that you make these kinds of choices. Granted, you're talking about a situation that's at the top end of
Right.
responsibility, right? It's very severe, and not every call you take is that severe, but sometimes you run into these that are that severe. And I'm wondering about repeated exposure to trauma over time, right? And your own mental health and the mental health of those in your profession. How do you notice folks navigating this repeated exposure to trauma over time?
You know, there's a lot of effort being put into mental health in the first responder world. When I started out in the 90s, it was just really starting to even be talked about. I mean, if we just go back in time, even into the 80s, and we talk about substance abuse, which is obviously tied into a lot of the things that we see, that's a way that people use for an outlet when dealing with um, burnout, dealing with the over repeated trauma of the job. That's, definitely one of the things we see. We see suicide, we see substance abuse. Those are the top things we run into. We also see, poor health, from stress, chronic stress. There's a lot of indicators that you can look at both personally or try to observe in your coworkers. But if we go back into the 19, it wasn't until the 1980s that we, even as a medical community, recognized that substance abuse was actually a biologically, physiologically, a mental type situation. It was literally thought to be a moral failing up until that point. And so we're not that far. I mean, yeah, maybe 1980 seems like a long time ago. But we're not that far into this idea of mental health where it's really grown, and it's in emergency services. As I started to say at the beginning, in the 90s, we were just starting to introduce debriefings, teams that could come in to handle critical incident stress debriefings. It's a valuable tool. For me, I'll just talk about some personal ways to manage it that I found that worked great for me. Everybody is a little bit different, so that's the first thing I figured out. So I've worked with hundreds of different providers over the years, working closely with them on shift or on ambulance or fire truck, and everybody's a little bit different. But there's some common denominators. So for me, one of the first things that I found that was extremely valuable was talking it out. You see something bad, you talk it out. It doesn't mean you're talking about it like, this was bad. Oh man, this was bad, over and over again. It means literally just walking through the call, walking through, after we get back to the station, just as a group of the people that were involved with it, talking over what they saw. and being willing to express how it makes you feel. Um, Firefighters in general, most people don't. They're not the touchy feely type people, so they don't really want to get into the we'll use the phrase woo woo. I know we hear that a lot of times, but the woo woo concept of, we're going to have sit down and meditate and we're going to, hold hands and sing lovely songs or whatever. That doesn't happen in the fire service. What does happen is dark humor. Um, so dark humor is an outlet. It's something that we, as an educator, I share as a technique, but I also am very careful with, when is it appropriate? Where is it appropriate? There are times when you don't, if you're on scene, keep it inside. When you're back at the station with and if you're with people who also can engage that way, it's a way to have an outlet. Are we laughing about the suffering of other humans? No, we're not laughing about that at all. What we're dealing with is that buildup of pressure that's happening inside of us from being exposed to that and having an outlet for it. So, talking, dark humor, those are areas that I found for me, and I recognize them for what they are. So I'll just share a little bit. I'm, I've got my oldest son decided he was going to go into the fire service and didn't push him that way. It was something he did on his own, but he's now working as a career firefighter EMT. And, within the first couple months on the job, he had a really bad motorcycle accident that he had to run, extremely horrific. And I literally called me at home. It was in the evening. They were back at the station. And he was like, "Hey dad, I just had this call." And man, I just sat there just so glad I had been through every call I'd ever been through for 30 years and just let him talk it out. And we started talking and I got to the point and all of a sudden he made a joke about the situation. And I started laughing. I said, "There you go. That's it right there." And I said, "How do you feel?" He goes, "I feel like I shouldn't say that." I said, "Yeah, to me, you can say that. You don't say that to anybody else. But this is a situation where that stress is built up and keep talking it out." And so for us it's talking out. I think with therapists you guys have to talk to each other when you deal with, because you're getting downloaded all the bad stuff going on, right? Somebody comes to you and they're going to download all of their trauma, so once again you need to be able to talk that out amongst your peers as well, just like we do in the emergency services, to be able to manage that better.
I think that's good advice. I don't know that we always do that as therapists. I know that sounds strange, but I think sometimes therapists, especially in independent practice, it can be lonely. They can be on their own and they're often not talking to other people about this. I very much think they should be, but they aren't always. I'm curious, what what do you think talking about it? So you're talking about these sort of horrific situations, that you experience, and then there's something about talking about it that's useful. What do you think that is, to the best of your understanding? Why is it useful to talk about it?
I have a theory. So my theory is that the human body is a pressure vessel. So let's talk about an oxygen cylinder. That's a pressure vessel. It's a tank, and it holds about 2,200 pounds of pressure inside of it, that can be delivered out of a valve. Right. So in that tank there is a hole that lets the air in when it's being pressurized, and there's a hole that the air comes out when it's being released. If you just open that valve up, it comes out of there at 2,200 pounds and it's screaming and it's whistling and it's going to destroy anything that gets in front of it, right? That's oxygen. That's not very useful. But what we do is we drop a device over the top of that. We screw it into place and lock it down, called a regulator. And that regulator takes that high pressure and it allows you to have a controlled release of the pressure. And that pressure coming out of that tank now becomes useful. We can deliver oxygen to a patient and improve their outcome. We took something that's highly volatile and high pressure and we brought it down to something manageable. The human mouth is the regulator on our pressure vessel of our body. So when we talk, all that stuff that's going on in our head, all that internal pressure that's built up, the heart rate, the blood pressure, the physiological response, the mental response, has one outlet point. If we don't let it out of our mouth, it just churns in our head. It sits there and churns and churns and churns and builds up, and eventually, causes damage. If you heat up a pressure vessel, which is what happens when we're under stress, right, with the human body, if you heat up an oxygen tank, that pressure begins to rise. There's another valve on there that's called a pressure relief valve that will blow off once it reaches a certain point to keep the tank from catastrophically failing. And that's when, in my opinion, is when we have like a complete mental break, is that's our pressure relief valve that keeps us from just dying. I don't think that's necessarily textbook, but for me, it makes sense in my head. So I think the mouth is that regulator that makes it better.
Yeah, I think textbooks are boring, so I'd rather, that's why I have you here to talk about this stuff rather than to read textbooks together. So I really appreciate that, and as a therapist, I can notice something similar too, that there is something about just the action of talking and really talking to another human being, because we do
Yeah.
talk to ourselves in our head, and that can be of benefit too, but there's something about talking to at least one other human being that seems to be important, and I'm not smart enough either to know exactly what that is, but boy, the pressure you're describing, I've seen some of that too, and often I'll tell people that for therapists, it's really two things. One, it's talking, and two, it's relationships, right? And often if we're talking about this sort of thing, it's usually with someone we trust that we have some sort of a relationship with. And so there's something about just talking in relationship that seems to be healing in and of itself. Now, do we sometimes need more than that? Probably so, right? But like you were talking about, I don't know the exact metaphor that you're saying there, but when you said the pressure would come out and like kill anything in its wake if it built up too much, right? Yeah, that's where we're at risk. So if we can do this sort of more frequently, as you're talking about, as needed, rather than waiting for it all to build up. Okay, if I can, I want to circle back to something we were talking about. Well, really, you were talking about it, but I took some notes because it was of interest to me. Where you were talking about psychiatric calls that you get, right? Where you may see a person who's experiencing a psychiatric emergency. And I think for therapists, especially in the modern world, there's often some hesitation. I mean, it's something we have to do. Like we have a legal and ethical duty, right, to make sure we get people 24-hour care who need 24-hour care, and outpatient therapists can't provide that. So to be clear, it's a legal and ethical duty. And also, I think sometimes there's some hesitation in the modern day about calling police, calling EMS. And I'm wondering if you can give us sort of the other side of that picture, what it's like for you when, you get a call about a psychiatric emergency.
Yeah. Psychiatric emergencies, behavioral emergencies, can be some of the most challenging calls we run because we're dealing not with a broken arm or a heart attack, something that we can give a medication for. I mean, there are medications we can give with psychiatric emergencies, but those are band-aids on an issue. Those aren't fixing anything. Um, we can't splint it, right? We can't put a splint on there. We can't so we can't fix the problem in most cases. So what we do in these situations when these calls come in particular is um, number one, talk, right? Try to engage in dialogue with the patient if at all possible. Now we have those situations where we have somebody who's really they're hopefully they don't show up at your therapist's office in this state, right? I'm sure it can happen, but many of these times these are people who are almost to the point they're non-functional. They're so out of control. People are recognizing a problem and they're calling in for help. So for us, it's always de-escalation. There's a whole lot of training that we do in emergency services to reduce the pressure on the mental pressure on the patient. Um, I'm going to come back to that word pressure a lot because it's how I relate to it. It makes sense to me. Let me give you an example. So this happened early in my career. I was a fairly new EMT, and I was working with a paramedic partner who'd been a paramedic for a long time. It was Halloween night. We got toned out for uh, a disturbance at a Halloween party, and we pull up on scene. Um, there's a party going in this house. There's glow sticks going everywhere, and music's cranked up. And outside in the front yard, there's a young guy standing against the house, and about 4 or 5 police officers in a semicircle around him. You know, all leaning in, all in that aggressive posture, and he is just amped up. He's agitated. He's almost to the point of being violent. And uh, in this situation, the emergency was caused because of a drug reaction. So he ended up getting into some drugs he didn't know he was going to get into, and he was actually on PCP. So it was a pretty significant event. However, it wasn't. Um, it, there was that problem we're concerned about, but it was also it's affecting the mind, right? That's what the drug is doing. And the same thing is applied in other calls. So I'm going to use this one as an example. My partner, who has been involved in this in EMS for years, at this point in his career, walks up, and the first thing he does is he comes up there approaches slowly with a real calm voice and asks the police officer who's in charge. It says, "Hey, would you guys mind just taking about 2 or 3 steps back?" Very first thing he does. Doesn't tell him to leave, doesn't tell him to go away, just asks him if they'll back up. They take 2 or 3 steps back, and the guy immediately starts to calm down. So what happened, right? And I'm this is in my mind, I can see this. This is, almost 30 years ago, and it still sticks in my head because I'm like, "Whoa, what did he just do?" Took the pressure off of him, right? Now the guy's not feeling so much pressure. And then he begins to talk with him in a calm voice. Eventually gets him to agree to come with us quietly, and basically says, "We're not going to have to put you in handcuffs and take you if you're quiet." Now he was assuming some risk, right? We have a person who could become potentially violent because of the drug they're on. We didn't know what it was the time we found out later. So, but he had been around those situations a lot. We get in the back of the ambulance, and this is where it gets a little interesting, unconventional. Um, he says, "Hey, run inside there and grab a couple glow sticks and bring them out here for me." I'm like, "Okay, why?" I'm the new guy. I do what I'm told. So I run in and bring these glow sticks out. Turns out all the lights in the back of the ambulance has the patient lay down on the stretcher, gets him strapped in and secured, talking to him quietly, hangs these glow sticks up in the back of the ambulance and begins to just talk to him in a soothing voice, um, addressing whatever fears or concerns the guy is having or experiencing. And then, he tells me to put on some quiet music and drive slowly to the hospital. That's what we do. And we walk into the hospital with this patient calm. Not, I mean, he's still, still physiologically responding to the drugs in his system, but he's not agitated anymore. He's calmed way down because he created an environment of low pressure for him, right? We get him in the hospital, and the very first thing they do is they flip on all the lights in the room, put the spotlights on him, start poking and prodding, and the next thing you know, they're calling security because he's out of control again. And so I walk outside and we have this conversation. I'm like, "What just happened?" And he's like, "Well, here's what's going on," right? He's explaining to me what was happening to this patient and why he did what he did and why he's seen this before. And so that was a big early in my career. I had that big aha moment of, if we got somebody who's feeling completely stressed out mentally and they're having a significant reaction to the situations that are around them, let's pull some of that pressure off of them if we can. There are times we can't, right? There are times somebody's violent and we end up, for us, we end up having to tackle them and restrain them. We hate to do it. It's at the very far end of everything we try till we get to that point, or law enforcement gets involved. What we don't want is if we can, we don't want them to get tased or shot. I mean, that's what we're really trying to avoid, is that escalation into the really serious side of it. So anything we can do to reduce that. So we're non-confrontational, right? We're going to try to play along with it. If there's a break with reality, I had a young patient one time who was a teenager who had a complete mental break with reality. Mom called us. He was and said he's just out of control. And we walk in the house. A 16-year-old kid is talking nonsense. He doesn't recognize who his mom is, and just completely like. And we're like, "Is there drugs?" Not that we know of. And come to find out, we did end up putting him into a 72-hour hold. Was what happened with him, and it was a mental break that happened. It was the first time I've really actually seen it. Read about it in the books, but never seen it. And in this case, he had been playing video games for like 6 days straight, almost nonstop. And his brain had gone into he was in the video game. That's what he was talking about. He was calling for helicopter extraction. He was calling for stuff that was in this game. And once we kind of realized what was going on, I know maybe textbook says don't do this, but I'm doing it every day of the week because it works, which was I just engaged with where he was at. Right. So that's what we did. We just entered into it. We're like, "Yeah, we're here to take you out. We're going to sneak you out." We put a blanket over him so that nobody would see him coming out of the house, and he was happy, right? Once again, we tried to meet him where he was at, reduce his stress in whatever state he's in, and get him out and get him to the hospital so he could get the care that he needed there.
I really appreciate these stories and the idea of meeting someone in crisis, or anyone, but especially someone in crisis where they're at. And I think the fear therapists often have, like the first story you gave was really interesting because it sort of gives, I think, therapists' biggest fear is that people may engage, EMS, police, whatever, may engage in a way that escalates the situation, right? And there was some escalation that occurred, but then you and your partner came in and it de-escalated the situation, which is, I think, is what therapists are hoping for in this sort of situation. And then, the way you just said, "Well, I know the textbooks say not to do this," and I'm thinking, well, maybe the textbooks need to be rewritten because I, this is something you'll hear therapists say all the time: meet people where they're at, right? Meet people where they're at. And sometimes when therapists do that, I mean, they can be accused of like jumping into the patient's delusion or whatever it is. And it's like, well, there's something about intervening in a crisis situation in the moment, trying to get a person to a place where they're safe. That's very different than like a long-term treatment and what you're going to be doing over the
Right.
long term, right? These are two very different things. And so I have a lot of hope in hearing the stories you just shared because it tells me that like there are people, and there, of course, therapists are doing this too, right? There are the textbooks, and then there's the people on the front lines actually doing the work, and those two things aren't always overlapping. Sometimes people are doing what works, even if it breaks from what's in the textbook.
Yeah, and I mean, it comes down to, once again, how many billions of people are on this planet. We're not all the same. Every one of us is unique, and so you have to meet the person where they're at. There's no other way around it at the end of the day. So, um, yeah, when I say the textbook, I just, going back 30 years, it was a very, very first EMT textbook that I took class out of, and um, I reference that just in my head every time I say that because there was a phrase in there that said, if your patient says they see pink elephants, you should tell them, well, I know you see pink elephants, but I don't see pink elephants. And I remember this phrase sticking with me. And I remember just laughing hysterically about it at the time as a fairly young person. And it did bear out over the years that that was probably not the best advice that there was out there.
Yeah, we got to write some new textbooks. Um, Gosh, thanks for sharing those stories. I'm going to pivot if I can. I want to spend some time talking about death and dying in particular, because this is something that in your line of work you see. I'm going to start in a general place and say that as a culture, it doesn't seem like we talk well about death and dying. In fact, it doesn't seem like we talk much at all about death and dying. And I'm wondering if you share that observation. And then if you do, how the fact that we as a culture not talking about death and dying, and you're in these situations where you're up against death and dying, what that's like for you in a culture that doesn't know what to do with it.
Yeah, we don't talk about it as a culture for the most part. I think there may be some movement in some areas to improve a little bit of that. It is fascinating to look at other cultures that have a huge end of life belief system and culture around like the whole. There's it's in some cultures there's two sacred moments, right? There's the moment of birth and there's the moment of death, and I love that concept, right? Those are the two most important. They're the bookends of what we call life. Why would we not talk about one when we talk about, everybody has pictures of big. I'm not saying take pictures of your dead loved ones. That's not where I'm going here. But we all have pictures of the babies, right? We have baby showers. We have all these things about life coming in, but we don't even want to touch death. Um, when in fact it's a perfect moment to, I mean, if possible. So the perfect scenario is if I have my choice, I'm an old person with my loved ones around me and saying goodbye, and that's great. That I love it when that moment happens and I'm involved with it, and which has happened a few times in my life, where I'm with somebody as they die who's an older person who has their family there. Um, nonviolent situation. Those are great. There are situations where people die traumatically or in violent situations, not as pleasant. However, being able to engage with your friends and family and loved ones, those who are still alive, talking about it, honoring the person's, memory in their life. I think there's ways we learn from, it's a great point in time to talk about what that person has done in their life and learn from that as well. So, culturally, yeah, I think there's some things there from the aspect of how do we deal with the situation where we have somebody dying. Um, it's something that's an evolution I went through in my career and in my life, which was, early on was we did everything we could to keep somebody from dying, right? That's why we're taught CPR. That's why we have all these heroic efforts we do. And the expectation was that if you call 911 and the ambulance or the fire truck comes and your loved one is no longer breathing or is their heart is stopped, that we're going to do something and bring them back. Um, the reality is that it's, depending on which literature you look at, 5% of the time there's a resuscitation that's successful. In some areas, with some studies, have gotten as high as 10, depending on different factors. It's a very small percentage. So much so, I even had a student a number of years ago who went through an EMT class I was teaching, and we got to this point and we're talking about it, and he was like, "I don't want to be an EMT if I actually can't save people." And I was like, "Well, you're going to be able to help a lot of people out who are not at that point, but once somebody reaches the point of no return, unless you have a connection as some type of a being that has power over life and death, then you're gonna be a little bit disappointed that you don't save everybody." And so he actually decided he didn't want to become an EMS provider at that point, which was good recognition. So the evolution started with this idea of let's save everybody. And uh, well, let me share. Stories are a good way to share information, I think. So one of the very first calls I ran, I mean, I probably had gotten out of EMT school less than a month, 3 or 4 weeks earlier. I was just volunteering in this little tiny rural community, and we were dispatched for an unconscious, unresponsive person, and we arrived on scene. And I'm with a paramedic and a couple of firefighters and EMT paramedics who have been doing it a long time. And we come to the door of the house, and it was an older patient, obviously deceased. We did CPR for a little while. Then the paramedic said, there's not any reason to continue CPR here. That's, they're obviously deceased, and they went through the protocol for that. In EMS, the decision to stop efforts is done by local protocol, but in general, usually there's a physician involved. We usually call them and talk to one of the physicians and explain the situation, and then we can stop. Paramedics can terminate the efforts at that point. So that's kind of what was happening. I'm new. I'm like, whoa, like this is like a real person who's dead now, and how am I going to deal with this? Trying to work through that. I'm also this, with a podcast and no video. If you listen to audio only, just to give you a little background, I'm this uh, Caucasian kid who's grown up in an ultra conservative home and hasn't really been exposed to much of anything in the middle of America. Right? That's kind of where I was coming from. And I was in a home full of people from an ethnic group that had a completely different take on death than I'd ever seen. So, like, my upbringing was like kind of like a German town, like very stoic people, like somber. So I'd been to funerals. I'd been around death at funerals, but I hadn't really been around a death where all of a sudden there's wailing and a lot of like hitting of themselves and stuff happening. And I'm just like, what? Now I'm starting to panic. Like, what's going on? Are we going to get attacked? What's happening? And I think the fear must have shown on my face, and my paramedic partner looks at me, he just started laughing. He said, "This is a cultural response. This is how this culture of people respond to this situation." And, over the years, I've dug deep into that because I'm interested in it. I wanna know, how do different people, different religions, different cultures respond to death? Because, that's what we're made up of. We're made up of our upbringing, and then all of our experiences makes us who we are. And, so I wanna know more about everybody. But yeah, it was an eye-opening experience to realize, "Oh, guess what? Not everybody's the same as me on this planet." It was a good moment for me, another aha moment, um, to work through that.
Yeah, that's really interesting. I'm not sure everyone would have the same response that you had, Scott, where it'd be like, oh, I'm going to dive into this and learn about sort of cultural differences around navigating death and dying. But it sounds like something you've done, which makes me wonder, like, what have you learned over time seeing about different people and different cultures respond to death?
Um, one I've learned is that just because somebody is a certain ethnic or cultural group doesn't mean they're gonna respond the same way as everybody in that same group. So, guess what? I figured out again, we're all different and unique, even down to the individual. So, don't judge a book by its cover right off the bat. I don't, and this ties into my other, like, my foundation of everything I've ever done as an EMS provider, and that's that the back of the ambulance is the most sacred ground on the entire planet. I've made it that way in my mind, and I teach that to all my students. It's the one place on this planet where we don't care what color your skin is. We don't care what your political party is. We don't care what your social views are. We don't care about anything at all about it. You are a human being who needs help, and we are a human being there to provide care. We put, our goal is for us to take all of our preconceived notions and ideas and leave them on the shelf at the station when we run a call. Now, obviously, we're human. We can't dump everything as much as we try to, but as I mentioned about my upbringing, that's part of who made me who I am, but it doesn't mean that that's who I am, right? That's just part of the journey that you're on. You have a completely different journey. This is why it's fun, right? You and I can sit down and talk, and guess what? We're getting a point of view from two different, completely different angles, and there's no other points of view the same as you and same as me on this planet. So we might align on a lot of things, and we might be off on other things, but it doesn't matter. That's just who we are. So with death, it was an area that, because I dealt a lot with it, that I really wanted to understand that better. So yeah, I did dive into that and research it more because I just wanted to know, well, ultimately how to meet the need of people, right? So once the patient's deceased, we can't do anything for them, but everybody else around them now needs help. So we just, our patient went from one to whatever the group size is that's there at that moment in time.
Okay, now you're bringing up something else that I think is really interesting. What have you learned about working with family members in these moments and having conversations about death and dying? Or maybe it doesn't involve words. Maybe there are other, maybe it's just a presencing, but what have you learned about supporting family members through death and dying?
The number one thing I've learned is to be open and honest with them. Be kind in your tone and your approach, but don't try to hide or cover up things. What I found is that we all think other people are going to be more squeamish about death than they probably are going to be. And if you invite somebody into the moment, um, it can make a huge positive difference in how they process their grief. So I've got a couple stories to share that really drive this home. Uh, one was a call we were dispatched for, a 50-year-old man who had collapsed. He was downstairs in his home playing guitar with his best friend. They've been best friends since like grade school. They were jamming out, and he had a massive heart attack. His wife is upstairs. We get on scene, we get down there, and we do everything we can under the sun for this guy. And as the lead medic on this call, I'm a well-seasoned paramedic by this point in time in my career, and we're running through every round of advanced cardiac life support that we do. We do the exact same thing with the exact same drugs that the ER does. So we are doing everything that they can do in the hospital. Um, at this point in history, that was the case. Today, there's some technologies that have been brought into the hospital that are even better now that can be available that we don't have in the field. But um, so I worked this patient for a period of time, and there's different CPR rules change over the years. And once we used to load them in the ambulance and transport right away. At this point in the time, it was work them on scene, keep them stable, don't stop your compressions, just keep working this patient until you either get pulses back or you can determine that they're not going to be revivable. And that's what we did. So we reached the point. I called the ER, talked with the physician that was on call, told him what was going on. We made the determination to stop CPR efforts. And during this time, I had a crew working with me. So I had a fire engine and ambulance crew with me, and I was had a medic chase rig I was on, and I had the officer from the fire engine going and talking to the wife and this guy's friend, and giving them updates every few minutes. Here's what's going on. And when we made the decision to stop, I got up, cleaned up my gloves and stuff, and I asked the team. I said, "We're going to have the medical examiner come to the scene because it was an unplanned death. That's going to be part of what happens. So um, we have to leave, like the tube we intubate. We have to leave certain things. The IVs have to stay in place for the medical examiner to see." That was the protocol. I said, "Otherwise, clean everything up. Get the mess, the trash, the debris that we've made. Clean this thing up." I went upstairs and talked to this lady and just said, "He's dead." Right? It's brutal, right? That's a hard thing to say. I have a hard time even getting it out of my throat, but I needed to let her know all the efforts have been done. And then I went through what we did in layman's terms. Um, and what she needed was she just grabbed a hold of me and started hugging me and crying. And other people would freak out. We were talking about it afterwards. One of the firemen was standing there. And he's like, "Man, why didn't you push her away?" And I was like, "Because that moment in time, all she knew was that her world had just collapsed. She needs just something to hold on to keep her afloat." So that's what you do. You let them cry on your shoulder if you need to. And then it was, here's what's going to happen next, right? Law enforcement will have to come. Actually, they were there at that point. They have to do an investigation. That's just part of the process. And when I explained those steps to her, She had the friend there already, which is great, and he was helping to start calling, kids and family and whoever else they needed to call. And I said, "Do you want to see him?" Because a lot of times we drive them out of the room, the patient's deceased, and they don't ever get to see them until they're at the funeral home. And so she said, "Can I?" I was like, "Yeah." And she was scared and nervous, but we came down there and I cleared everybody out of the room. And I said, "You can sit here and talk to him. You've got time." And she sat there for about 10 or 15 minutes and talked and cried. And then she got up and came out. And I get a little choked up talking about the call just because it was something that was one of those moments where I was really putting things together and realizing what an impact this could have. Um, so long story short, we clear the scene. um, you know, Medical examiner comes, everything's cleared and they took the body away, did everything that they do. And we ended up going back to the station. I ended up staying on scene there. We were there for about an hour and a half, which is not normal for a call like that. But it was just one of those situations where by our presence, we're providing some stability for somebody who's in an unstable moment. Um, it was 2 weeks later, I come into the fire station and one of the guys is like, he's like, "What did you do on this? Who is this person?" And he says the lady's name. And I was like, "Oh, I know who that is. Yeah, her husband passed away a couple weeks ago. We ran that call." And he said, "Well, she brought stuff for you guys. She brought stuff for you at the station." I went upstairs and there was this cake, the biggest cake I've ever seen that she had on the table. She brought up for us, thanking us for what we did. And I was like, "Why would she bring a cake?" Um, well, this happened over the course of about 6 or 7 months. I had several other calls where we began employing this concept of trying to be a little more kind, letting people say goodbye to their loved ones, doing these things. And we started getting cake after cake, and the other shifts were laughing at, like, coming up to be like, "What are you doing?" I'm like, "I'm treating people like humans." That was my response. And so if you want to get cake, treat people like humans. That was my response to them. Obviously, that's some of my dark humor coming out, right? We're not doing this for cake. Um, but that was a situation, where we had to meet the need like that.
Yeah, I appreciate the story. I was getting choked up hearing the story as well, and there's something beautiful and human about what you just described. We're treating people like people is essentially what you're saying, and in these moments, perhaps people need that more than at any other point. And then some of the dark humor you were talking about showed up too. One of the things that I think therapists wrestle with a lot is and it's slightly different because often we're getting it in story form. You're getting it more in the form of lived experience, right? In the story you just told. But the question I get from therapists just coming up are like, and they ask me, they say, "How do you not take all of this home with you at night?" And to be honest, I don't always have a great answer to that. And I'm wondering if you can begin to construct an answer. How do you not take this home with you at night?
Yeah, it's a challenge. I don't know that I have the answer to it. I know what's worked for me. So I've got very close friends who have nightmares. They see their patients' faces. These are people I've worked with closely. They're excellent providers. Never had that happen to me once in all these years. Part of it is I think I employ some mental gates. I think that's what I've kind of done. That's the best way to describe it. So, for example, when I'm in the back of the ambulance, I make I'm trying to think of the right word here, conscious decision to treat them as a human being. So, but I also put them into the category of patient, which dehumanizes. I don't want to, not in a negative term, but that takes some of it away. So my whole response is about treating them as a good human, but it also is I don't memorize any features. So I'll have a patient who will come up to me 2 weeks after I've taken care of them. I will not recognize them. So I don't I focus on them. I'm looking at them, but I'm doing it from a clinical assessment perspective. And I'm not, for whatever reason, my brain is designed this way. I'm not mapping like their facial features. Uh, I even had a lady come up to me one time in a grocery store. I was on shift with my crew, and she like tackled me in in the aisle and was hugging me. And I'm like, "I'm married, lady. Like, I don't know who you are." And I did not recognize her at all. And she was just ecstatic. And like my captain had like got her up off like literally she knocked me to the ground. Like it was crazy. And she was just like, "Thank you, thank you, thank you." And I'm like, "For what?" She's like, "For saving my baby." And I'm like, "I have no idea who you are." That was when I realized, like, oh, I'm not memorizing. Once she explained who what the call was, it clicked. I recognized her then. I knew who her child was, but until that point, I wouldn't have even recognized her. So there's been that aspect. And then for me, it's um, talking it out. Maybe that keeps it from being ingrained into my head, so I don't have those deep grooves in the brain that store all that. I don't know if that's a good way of putting it, but I think talking it out for me has helped not hold on to it. I'm also fortunate because I'm married to an RN, to a nurse, so we can chat about the physiology and the all the medical side of stuff, which has been a blessing for me.
You said something early in this conversation about death and dying that really struck me. You said that when you're performing CPR, it depends on the study or whatever, but it's like a 5 to 10% success rate.
Yeah.
I never knew that. I mean, I remember when I was a basketball coach 20 years ago in high school, coaching high school basketball, I was trained in CPR because I had to be, right? So I went through a class on a weekend or something like this. But I'm no expert on this by any means, but just something, the psychology of 5 to 10%. And, so y'all engage in this when you have to, but you know that the odds of success are so low. I'm wondering just about that process. You gave the story where one person was like, "Hey, if I can't sort of save most people, I'm out," which, good self-awareness, and probably that worked out best for everyone. But for those of you who stay in and you're engaging this, but the odds are overwhelmingly stacked against you, I'm just wondering about the psychology of that.
Yeah, like I said, this is part of my process with handling death was especially as a paramedic. So this comes into like quite a provider level because EMTs don't typically pronounce somebody dead. They usually have a higher provider level come to the scene. Um, so the way I look at it is, what is the chance on this patient? I don't care about the stats for anybody else. So if this is a young person, so you use the high school, coach scenario, you have a high schooler who collapses during practice or at a game, and you're right there, man, you got the very best chance. You're on scene, you saw it happen, you're going to start CPR right away. There's probably an AED in the building somewhere they can get to put on them. The fire department, we're gonna work that person to no end. They're gonna get the very best because they've got the best chance. They're young, they're probably healthy. There probably some underlying problem that caused it. Um, so it's gonna be a recognition of that. It's so when I come into the situation, I'm not thinking about that 5 to 10%. I'm thinking about what is the story I'm dealing with today. And is this somebody who's got a chance or not? And if I walk in and they're 95 years old, um, and they've had cancer and the family's saying we need to do CPR, I'm gonna have a real long conversation with them about why we probably shouldn't be doing that, and we're probably gonna pronounce them pretty quick. Just because there's more dignity in not, doing CPR on somebody that old. We're gonna break a bunch of bones. There's no chance they're gonna survive in that situation. That's the zero chance. Whereas that young person, who has a traumatic event, but it's witnessed and there's care started right away, yeah, so it's for me, it's all about that patient, that story, that situation, and then that helps guide me on what I'm gonna do decision making wise on, efforts that we do. Do we transport? Do we work them here? Do we call it? That sort of stuff. And I also know that I know the stats, so I don't let it get me down. It's like I don't think of this as a game where I'm trying to win. It's just a patient I'm trying to take care of, and I'm okay with the fact that, yeah, most of the time this isn't going to be successful because I recognize that and I'm okay with it. Then it doesn't weigh on my shoulders when it goes that way.
I'm struck by a theme I'm seeing in our conversation, Scott, which is that you're meeting people where they are. You're treating people as human beings, which, I mean, that can sound not radical or something, but I think there's a risk for any of us that provide care in some way to human beings, and we do this over and over, day in and day out. We can lose the humanity of people, not because we're bad people or that it's intentional. It's just day after day after day, we're at risk for losing sight of the basic humanity of people. And as I'm listening to you today, it seems like this is something you try to keep close to you, people's humanity, that they are human beings, treating each story as an individual story, each person as an individual person.
Yep. I think that's the only way to stay sane.
Hmm.
Maybe not the right word to use on a therapy conversation.
Yeah, in a colloquial sense, you say insane. I know what you mean, but I think that we've all seen people in professions that are dealing with people in crisis over and over and over again, where it does take a toll on them, where they can start to sort of feel disconnected from reality, and in worst case scenarios where people lose the will to live, and
Yeah.
that can feel like people are disconnected from who they are as people, like, they can feel literally insane, so I understand, I think, what you mean when you say that. In closing, I'm wondering, is there anything else that, we've gone through? I've really enjoyed all the stories and learning about some of what you've done, navigating crisis situations and death and dying. As we've been talking about this, has anything else come up in your mind or heart that you want to share that you think might be beneficial for therapists or anyone else to hear?
Uh, we didn't get to go down the rabbit hole of pediatric response to death, and I won't go real deep on it, but I think that's one area that's super important. It's an area that really became really important to me after a couple of calls where I ended up talking with kids later who were on scene when I was working on a family member who passed away. And what I've learned is that there's a curiosity there. It's usually um, the kids are usually shoved to the side. But if you can engage with them and let them ask any question and be as honest as you can, obviously within reason of their age level, on how you respond, um, you know, we can see tremendous benefit in their grief processing. So that's something that we implemented in one of the departments I worked for, which was when we went and worked a call where a family member died and there were children in the home who were there during that time. We would come back usually after the funeral. So give a period of time and we'd come back and we would let the kids ask us questions. One of the hardest things, the first time I did it, is the hardest thing I've ever had to do. It's because kids are blunt, right? They were like, why didn't you save my dad? Like that was the first question. And we talked about, well, here's what we did and here's what we couldn't do and here's what the outcome was. But because we were honest with them and let them talk it out, we followed that family in particular. I followed up with their mother over the course of about 2 to 3 years, and then I kind of dropped off. And it was fascinating because this 8-year-old kid who'd asked me that question, this was many years ago. Fast forward like 12, it was like 12 years later. I'm at a fire department I was working at. We were doing a test for the fire department, and it was an open door test. Anybody can come in, and then they go. If they get hired, they go through the training. And this kid comes up to me, and I'm doing the registration desk, and he's talking to me, and he's like, "You don't remember me, do you?" And I'm like, "Nope, don't know who you are." And he was like, told me who he was. That 8-year-old kid. So 12 years later, he's like, "I decided I was going to go into this line of work because of how you guys handled that situation with my dad." And I was like, "Oh, like that's when it really hit home that you know kids in particular need to be given a chance to talk this stuff out." So yeah, that's my last little tidbit, I think.
Oh, I'm so glad I asked that question. You shared that because I think so often kids are left out of these processes, right? This is for the adults. I mean, not just around death, but maybe especially around death, and they aren't considered, or sometimes the truth's not told to them, but kids know, right? They're paying
Yep.
attention, and kids are smart, and they have a sense of what's going on, and so often they're not a part of the process, and the way that you're talking about including them and even circling back, weeks later where they can ask these questions, and then I was struck by when you said, it's like the hardest conversation you've ever had there was when, and you're right, kids don't have that filter. They'll just ask you. And this 8-year-old says, "Why didn't you save my dad?" And then there's something probably, to use language in my field, there's something therapeutic that's probably going on there. But then I'm imagining, boy, that's a lot to ask of people in your position as well.
Yeah, but it's therapeutic for us too if we accept it as that. So, and that's what I did. It was like I knew it wasn't an attack on me. It was a legitimate question, and I knew that it didn't matter what my answer was. It was going to be my tone and me conveying that we cared, and that's what we had to do. So,
Mm. That's a beautiful way to end this conversation. Scott, I appreciate your time. I could go another hour easily. Your stories, the sort of human touch that you bring to the work. And I'm really excited
mhm.
for therapists to get a chance to interact with some of these stories and ideas. I really appreciate your time.
Yeah, thanks for having me.